on we go to our next panel. And this one concerns something of really enormous importance, I think, which is inclusive healthcare improvement research. I mean, it's something we've mentioned again and again. I mean, inclusivity is an important ethical principle in improving healthcare. And this research explores the concept of inclusivity broadly. It looks at how research needs to tackle the need for inclusivity head on. And one imperative, I guess, is to make inclusion a key focus for inquiry, for instance, by creating the evidence base for design of systems that take the needs of many stakeholders and avoid marginalizing or disempowering people or particular groups. I suppose we've really been made aware of that through Caroline Criado Perez's work, which has shown how design in and of itself can sometimes inadvertently result in women being systematically disadvantaged. So inclusivity in research also means not only doing that, designing for inclusivity, designing, as we were talking earlier about designing your ethics into your studies from the beginning, but also including and valuing different types of voices. And the way research is conducted also needs to be inclusive. In trying to advance inclusion, it's also important to treat inclusion itself as something to be examined and scrutinized. Not all our efforts at inclusion are going to succeed, and sometimes there may be unintended consequences, but it has to be top of mind. Once again, we've got a top panel. We've got Graham Martin, direct from Illinois, and you're very welcome, Enid Montague, and finally, Sarah Ray. And yes, hello. So, would you like to each introduce yourself? Let's start with you, Graham.
Hi, everyone. My name is Graham Martin, Director of Research at the Healthcare Improvement Studies Institute, involved in various this institute programs. Perhaps most relevantly for this panel, I've also done quite a bit of research on the involvement of patients and members of the public in service change and in research in healthcare.
Enid. And hello from Illinois.
Hi, I'm Enid Montague. I'm an associate professor at DePaul University and Northwestern University's Feinberg School of Medicine. I'm a human factors engineer by training, and most of my research is about patient-provider communication with an emphasis on cultural critical theory.
Thank you. And finally, Sarah Ray.
Hello, I'm Sarah Ray, yes, from Cambridge. I'm an independent expert by experience. With my background is really in mental health. I also work as a service user researcher, and my aim today is to bring very much patient perspective to the discussions.
Thank you very much. Okay, so let's now talk to you first of all, Graham. How do we know when improvement work or research is really inclusive? What are the metrics that we can use?
Yeah, well, I suppose I'm going to give the obvious answer that a researcher would give to a how can we know type question, which would be through data, whether that's qualitative data or quantitative data. And I suppose what I mean by that is that clearly the inputs into a research process or into a service redesign process, into an improvement process are crucial. But we really need to evaluate whether and how far it's worked in terms of the outcomes. Now, I suppose the important caveat to that is that in order to be looking at the right outcomes, to be measuring the right thing, to be using the right metrics, then it's very important that we have the right people involved from the start, because, you know, through no particular fault of our own, we all have limited scope of vision. We all have certain areas that we don't see. And so a diverse process of research, design, research activity is what helps to secure those things. So that includes defining what those measures should be to start with and ensuring that different affected groups, be they demographic groups, staff groups, different groups of patients are involved in that process. That's crucial to ensuring that you can then determine whether or not an improvement process or research study has been inclusive. So it's really, to answer that question, you have to ensure that the right people are there to make those data meaningful so that you can have an answer that is inclusive.
Enid, how would you take that question?
I agree with what Graham said. I also think that it's really important to make sure that when we are doing our end evaluations, that we are really evaluating for equity and unintended consequences for varying groups, but also making sure that what is valuable to them is also included in those evaluation measures. So really having a diverse team, inclusive research approaches, but also including those factors in the evaluation of whether or not it was inclusive for the people that we're trying to design for.
Graham, I wondered how you resist the pressure not to be inclusive. And when I say that, I say it because it's sometimes easier, quicker. To be inclusive takes a lot of time, and people are under enormous research pressure. And sometimes they will skip that inclusivity bit because they feel that it takes too much time, or it makes their research too expensive. How do we persuade people that actually inclusivity is absolute bedrock of what we should be doing?
Yeah, I think there are various steps we can take, and I think we have made steps forward in that regard. I mean, I think what we really want is for people to be committed to inclusive research because they can see it's better research. And I think a lot of people believe that in principle. But as you say, when it comes to the practice, it does take time and effort to do it properly. And I think there are probably some parallels with the earlier discussion around ethics here and the size that some people suggested that researchers give when they hear about ethics, because they associate it with regulation and they associate it with paperwork above all and with compliance. And certainly in funding research these days, we are much more attentive to the need for it to be inclusive. So we talk about patient and public involvement. We often talk about other forms of involvement. Many funders will focus on diversity as well. And, there is increasing attention to ensure that what used to be the default subjects of research, so often white and male, our history of biomedical research in particular is dominated by white and male research participants, which gives you a great evidence base for people who are white and male, but much less so for people who aren't. And there's certainly a lot more attention, I think, to ensuring diversity of study participant groups as well. So I think there's a combination there to be had between a degree of pushing and nudging and incentivizing and even forcing researchers to take inclusivity more seriously. But hopefully that is complemented by a genuine desire on the part of many researchers who equate inclusive research with good research.
Sarah, I wonder what your thoughts are on a very interesting question that we've had in. Should we seek a benchmark approach to inclusivity, or should we consider that some groups need tailored research?
I think we should consider that some groups do need tailored research. I think it's always going to be really hard to decide which those groups are. But we know exist at the moment that there are a lot of people who are underserved by research. We don't get to hear their views, and we do need to widen the pool of that pool of ideas. Does that answer your question?
Yes, and I was also wondering, and this again is another question that's come up, how co-design at the very beginning of a project with the people that you want to include can actually create the conditions of inclusivity right from the start. So that kind of idea of baked in right from the beginning.
I think it has to be, absolutely. It has to be baked in. It's not inclusive if it's not baked in at the beginning, to my way of thinking, because those people have to be on board from the start, co-designing, co-producing, and totally involved in that process. But of course, there are a lot of barriers for people doing that, particularly as you would ideally, you would want someone to be involved when the funding proposal is being drafted, and there's no payment until the research has been funded. So unless you can afford to work, without remuneration, it's difficult to be involved. So it's not very inclusive as it stands at the moment.
And actually, that goes back to the point I was saying, that sometimes the incentives are not in the right place. We make it too easy to do the wrong thing. Enid, how do we know what we're missing?
Well, I think it's you can start from the beginning. So I think that for a lot of the work that we're doing with improvement work, we know that there are existing disparities in our healthcare systems. We know that certain groups are underserved. We know that certain groups don't have the level of access. And so starting with those existing inequities can be really helpful in helping us decide which questions we're going to study and how we're going to study those. And then once we start from this goal of understanding the existing disparities and making sure that our goal is either inclusiveness or equity or eradicating those disparities, that's what can help us develop how we might actually evaluate those outcomes.
Where are you in the States with this kind of work? What things learnings have you got that you might usefully pass on to us here, the other side of the pond?
So in some ways, we have other underlying issues that lead to many of our disparities, but some of them are very similar, which is one reason why I think that having a more systems approach to understanding the disparities themselves can lead to better outcomes. So in the States, we have very large racial ethnic disparities where, wealthier white patients have much better outcomes, much better access to care, and people who are in rural environments, marginalized, and racial and ethnic minorities tend to have poor outcomes and poor access to care. So we don't have a universal healthcare system, and that's one big barrier. But we also have issues with implicit bias, different groups of people getting different treatment for the same illnesses, which are all things that I think that we could do a better job of identifying. One of the things that I think has been really good at looking at some of these is that there's been a lot more grassroots, patient-driven, community-based efforts to being involved in designing their healthcare systems and their community-based systems. And so a lot of the questions and initial work has started to come from the patients themselves, and then they have been reaching out to the researchers versus researchers reaching out to the groups as participants. And I really think that goes towards some of the work that Sarah is saying, is having inclusive approaches at the beginning and making sure that it's patient-centered in the beginning so that the work can actually be done with all of the finances and all of the existing things that you need for the work to be successful.
Thank you. And I was going to go back to Sarah to ask, how can the research community address, this is a question from Joanne Leading, how can research community address some of the cultural barriers that puts off some communities from participating in research?
Well, I think it's important actually to think about them as cultural barriers rather than talking about people as hard to reach, actually, because that puts the onus on the fact that there are cultural barriers, and it's not putting it on the person. So could you just repeat the question again for me? Sorry, lost my thread there.
It's so, oh no, I've lost the question now. Well, let me ask this one, which is, what are the ways can we ensure that we're asking the questions that matter to disadvantaged communities? How can we engage with them in a proper way? In a way that doesn't put them off?
Yeah, well, I think there's lots of things that we can do. First of all, we can start by addressing power differentials to ensure that decision making is more equitable. We can offer lots of training and support And that's really not about professionalizing patients, but it's more about bringing both sides to a place of commonality. I think researchers can do an awful lot more in terms of accommodating people. So, for example, meeting them on their ground where they're naturally meeting, or in a mutual space. And so, in terms of, and I think in terms of just thinking about who we do engage, and researchers being really innovative and imaginative about how they contact people, rather than just going to some of the individuals who are termed the usual suspects. I think those are some of the things that we could be doing.
Thank you. Graham, this is a question for Cecilia Land Avila. Sometimes it looks like an inclusion and diversity is only a tick box process in a research proposal and project. How can we ensure that there's authentic meaning in including diversity of participants?
I suppose that is the other side to the coin of what I was talking about earlier, which is the increasing expectation from funders, peer reviewers, and others that patients and publics and others be involved, but it's just done in a very perfunctory way. I think there's a number of steps you can take there, and I suppose the most obvious one actually is to ensure that it's more than a tick box. Researchers don't like to have more and more pages to fill in when they're applying for funding, but on the other hand, if they're given space at least to explain what they want to do at length, rather than reduce it to the number of meetings or the number of participants or something like that, then they can express their plans in a much more meaningful way. I think there's probably also, on the part of some researchers at least, two things. One is possibly a little bit of mystification about exactly what they should be doing there when they put in the PPI section in their application form, and that's in part because there are different purposes for patient and public involvement. It might be that you're trying to get a representative view from a wide range of different audiences. It might be that you've got specific areas of expertise or actually particular patient groups, particular publics can contribute, or it might be a combination of those things. So I think researchers are sometimes not sure about what they should be putting there. And then related to that, I think researchers can be a risk-averse bunch when it comes to a section like PPI, because they assume it will be evaluated on those relatively reductive indicators. So, we've got to do this, we've got to do that, rather than it being as an opportunity really to enrich the research, to be imaginative, to really look at how you can enhance the quality of the research by involving people in creative ways as real stakeholders, rather than as a group that's consulted once every 3 or 6 months.
I have to say that researchers are sometimes a bit frightened of the public. And can I just say, I know none of you on this audience do it, that public engagement, that public engagement is not a trestle table with 2 leaflets and your conference poster behind. That is not engagement, people. But unfortunately, I've had it in other areas. Enid, there's a question that we've had come through here about what the best way is of creating meaningful relationships and connections with grassroots organisations. What are your practices? What do you particularly do?
Well, I think that it's really important. There's a lot of different ways you can think about engagement. Like one of the top ways is to actually be a part of that organization and community. So I think that creating researchers that come from within the communities that we are trying to reach creates like a level of personal motivation and engagement that we can't replicate as researchers who may be researching from a different environment. So the amount of effort that it takes for me to understand what it's like to be a patient in a rural community that I don't live in is, it takes a lot more time than working with somebody that actually is part of that community. I think that long-term engagement and a bit of, just being willing to be of service versus being having a higher power differential. So for some of the communities that I've worked with, some of the things that they might immediately need, they might need you to hold a baby, they might have an immediate need where they need certain resources, and you have to be willing to participate at that level. The challenge for a lot of researchers is that we have certain kind of academic currency that we have to publish papers, we have to write grants in order for promotion. So a lot of that long-term community engagement work that it takes to develop trust and understand the community doesn't necessarily count, and it absolutely should. So I think the first thing is to work with a community that's close with you, if it's a place where you live, and then also amplifying people that live in those communities to be members of the research community.
That's very interesting. It's coming up again and again, that time that you need to put in to develop those relationships needs to be part of a grant proposal, and a funded part of a grant proposal, because it's actually critically important. Graham, what about NHS staff? We've talked about patients, we've talked about communities. What about NHS staff? And actually, what about healthcare staff for you, Enid? Let's start again with you on that one. How about healthcare staff? How do you involve them in an inclusive way?
For me?
Yeah.
Well, it's a little bit more challenging sometimes with healthcare staff because they have limited availability and resources. So right now I can see that it's, we're kind of at the heightened area of challenge in engaging healthcare staff, but, we really feel like they have important voices to say in terms of things like burnout and workload and their needs. And so being accessible and flexible and also giving them ample opportunities to participate in the, I think it's, more meaningful and having them participate in designing the questions that they think are important, and also letting us know how we can best involve them in the study, given their varying responsibilities, has been the most helpful, versus designing a study and then trying to recruit, very busy clinicians, and then potentially adding to their existing workload. So, we have similar issues in the US and the UK in terms of physician burnout and high workload and stress. And so those are things that we want to be really aware of when we're thinking of engaging them in these types of projects.
Graham, you're nodding. Do you agree with all of that? Because we sometimes kind of exclude healthcare staff, I think, when we're doing things. We don't think about inclusion in its widest sense.
Yeah, no, I'd agree with everything that Enid just said, and I think it's been a sort of a founding principle actually of the Institute that we see involvement and engagement as applying to staff groups as much as in an equal way to the way it applies to patients and carers and members of the public. And that's because, as I think Enid was saying, an awful lot of the things we research have really quite profound effects on the working lives of members of staff. And if we're talking about improvement research specifically, then it should be having a profound effect in a very positive way, because if you can improve systems, if you can make things that go wrong less likely to go wrong, if you can make systems more reliable, if you can just make day-to-day working life more pleasurable, and that's a big impact for staff. But there's a bit of a catch-22, because if the systems are bad in the first place, then frankly a lot of the time the last thing that's on many staff's minds will be participating in research. So it's been an important principle in terms of what we're doing at the Institute. And you heard a little bit about discovery from Ruth and Jan and colleagues earlier on, our online research and development platform. And a big feature of that is to try to provide opportunities for staff to make small but meaningful contributions to the research endeavour through surveys, interviews, consensus development exercises, to recognise them for those small contributions. So things like continuing professional development certificates and the like, they're not big, but they can make the difference. And I think also to try to build a community of staff and patients and members of the public with an ongoing interest in this. Because, and this comes back to the point that both Sarah and Enid were making about patients and members of the public, this should be a long-term endeavour. To build meaningful relationships takes time, and it's not something you do in a month or 3 months of preparing a particular project. So through Discovery and through the other efforts that we're making at the Institute, we are trying to create that community of interest, I suppose, and recognise people's contributions and make it easier for them to contribute in a meaningful way.
And do you think there needs to be a different view of improvement research by healthcare staff who perhaps think, oh no, it's them with the clipboard again? You know, they're bound to suggest something that we're not going to like. So is there that relationship building, as you suggest, is obviously very important, and maybe the view of healthcare health improvement research needs to change with people in the NHS?
Well, I think there's a lot of I think understanding of research in general is very mixed, and that applies to public, patients and staff. Certainly, I think the risk, speaking as someone who has done qualitative research in healthcare organisations, is that it's misconstrued as something that's much more focused on audit, that's checking up on people, that people have every reason to be sceptical about. So there's explaining to be done. I think this does fall mainly to the research community, and probably where it starts is ensuring that the studies that we're trying to carry out do have resonance with staff and with patients, that they're trying to address questions that they may not be the very first ones that they would ask themselves, but they can see that they have meaning, they can see that they have pertinence to their work, and therefore they're willing to engage, whether that's as a research participant, an interviewee, someone participating in quantitative research, whatever else it might be, or through those other means that I've talked about, including stakeholder engagement groups, very broadly conceived.
So it's a Quality Street initiative. So Enid, Quality Street are a particular brand of chocolates that we have in the UK, and they come in very large boxes or tins, and they have to be eaten all at once. That's the thing. but they're very good relationship builders, and of course you can't do that online. Sarah, we were talking about online in the previous session. What are the challenges, do you think, for inclusion online, and beyond those of just digital exclusion?
Well, I think the challenges online are, in one way it's an advantage. I know some people where it is a huge advantage, but you're excluding a great many groups. Maybe you may be excluding a whole range of older people. I think in terms of challenges, there's far more that could be done to address that, in terms of reaching out to people, trying to accommodate them. And so, for example, maybe saying, if you don't have the right digital equipment at home, you can come in and use this, laptop or something. So in that sense, I think we've got a long way to go in terms of extending the digital reach, if we really want to meaningfully involve people in research. But I do know that this was a question that Graham particularly wanted to come in on. So I'm not going to talk too much about it, because I know that was something he really wanted to have a word about.
So there you are. Your final word then, Graham.
Ooh, I'll be quick because I know we haven't got long.
No.
I'd agree actually with everything that Sarah's just said there. I think, something that has pleasantly surprised me about doing research online since about March has been that actually, the Zoom screen can be quite equalizing in a lot of ways. Everyone has an equal sized box. You don't really know who's who. So everyone has equal entitlement to speak, and it can be easier to ensure that different people have different amounts of airtime. But as Sarah says, it's sort of inherently discriminatory as well. So I think, as per the conclusion to the last session, it should be one part of a mixed media approach.
Fantastic. We've come to the end of our time. Thank you all for contributing. And should I say also that if you were expecting Sivesh Kamarajah, unfortunately at the very last minute, he wasn't able to join us. So Sivesh, wherever you are, we missed you. Come back another time. And can I say particularly a big thank you to Enid, all the way from Illinois. At least that's where I assume you are today, Enid. But anyway,
yes, thank you very much for having me.